Good morning, everyone, and thanks for joining the Clallam County EDC Coffee Chat, Coffee with Colleen. We're really happy to have Dr. Paul Cunningham join us this morning to talk about the care services offered by Jamestown Health Clinics. And as you can see, he's already got his slide up there, but just a few housekeeping items first before we kick this off. If you'll please keep yourself on mute or I will put you on mute so we don't inadvertently pick up background noise that interrupts the presentation. And if you have any questions for Dr. Cunningham, we like this to be interactive. So if you want to put your question in the chat and have me ask it, we can go ahead and do that. Or alternatively, if you'd prefer to ask your question, just please raise your virtual hand through Zoom and we'll call on you. So with that, Dr. Cunningham, thanks so much for taking time out of your busy day and presenting to the group here.
Well, good morning, Colleen, Mitch, and the rest of your team. Thanks for having me today, and good morning to everyone else. I see some familiar faces. I'm not too multimedia savvy here, so I'm not looking at all you, but thanks for having me. I know a lot of you. For those that I don't already know, I'm Paul Cunningham. I'm the Chief Medical Officer at Jamestown Family Health Clinic here in Sequim, and I'll give a little bit more of the history there in a moment, but I've been with Jamestown since 2003 when I landed on the Olympic Peninsula, moved out here. My now 22-year-old was a baby. My now 21-year-old was in my wife's belly, and both my girls grew up here, Franklin Elementary, Stevens Middle School, and Port Angeles High School. And so this is definitely my hometown, to say the least. I think you can see my slides here, so I'll start. I want to give a little bit of history because before I get into the heart of my talk, because I think for some of you on the call, you may know this, others don't, and I think it's relevant to what's going on in our healthcare world right now, and there might be some questions on that. But right now, Jamestown Healthcare, aka Jcare, consists of Jamestown Family Medicine from left to right on our slide, Jamestown Healing Clinic, Jamestown Dental Clinic, and the Tribal Wellness, which pertains to tribal health issues. I'll say a few things about that towards the end, and then I'll also say a little bit about our latest project, the Evaluation and Treatment Center. But before we can do too much history on Jamestown, I think you guys need to know a little bit about how I ended up out here on the Olympic Peninsula. And let's see if I can, how do I move my slides here? Oh, there we go. All right. So I was driving in today on Old Olympic past the Agnew Market, and I realized 39 years ago this week, I was doing circles in the Red Sea long before any off the coast of Sudan, Eritrea, and ultimately Egypt. And long before most of us heard of the Houthis and all that, there was a gentleman named Muammar Gaddafi, who was the president of Libya. And anyone remember who the president of the United States was in 1986?
I'm going to say Reagan.
Ronald Reagan. The first election, I was 18 in boot camp in 1984, and I got to vote for my first presidential election. Anyway, for then some who remember history, in 1986, April to be exact, Gaddafi was claiming domain over parts of the Mediterranean off the coast of Libya that others did not agree with. And I'm not a nautical expert, but I think the standard is 20 miles or 200 miles, and he was saying they wanted more. Well, that didn't go over well with the rest of the world, including the United States. So I was on board, that's me on the left. I was on board USS Truxtun CGN 35, which is a guided missile carrier. There in the middle, you can see the front of our boat, and off in the distance is the USS Enterprise, and on the right is another USS Enterprise photo. So President Reagan sent our battle group through the Suez Canal, which was the first time a nuclear-powered ship had gone through the Suez Canal. That was the Enterprise, and notably my ship, the Truxtun, was a nuclear-powered cruiser. Normally, I was down in the bows as electrical operator, but I came up above and took a couple of these photos on that day. So from there, I share this because then in 1989, my ship out of San Diego went into dry dock in Bremerton. And like a lot of people via the military, I landed in the Pacific Northwest and never looked back to my roots in central Jersey, although I still love Jersey and the New York metropolitan area. So that'll bring us up to Jamestown and a little bit of history. For those who've been around the peninsula for 22 years or longer, you may remember back in 2002, Virginia Mason Medical Center had a presence in the peninsula, both in Sequim and Port Angeles. And in Sequim in 2002, there was a group of physicians and other family medicine providers who kind of got fed up with what was going on at that time. And rather abruptly, the Virginia Mason Family Medicine Clinic in Sequim, which is old Sequim Medical Plaza, where orthopedics is now located, closed down pretty abruptly. And civic leaders, perhaps some of those of you on this call, were wondering, what are we going to do? Olympic Medical Center was wondering, what are we going to do, if this sounds familiar, in 2025? And then Dr. Michael Krim, one of my colleagues when I came out here in 2003, got together some civic leaders along with Cindy Lowe, our deputy health director, actually chief operating officer for Jamestown Healthcare, and others, and said, what are we going to do? And while the tribe, this is an abbreviated version, the tribe had not been in healthcare per se yet, they were keenly interested in making sure that there is healthcare available for Jamestown S'Klallam citizens and the community at large. And in 2002, Jamestown Family Health Clinic here on the left was born, and I joined them a year later. I think I was their fourth or fifth provider at the time. And so that was the origins of Jamestown Family Health Clinic. We'll go through the rest of these clinics as I move through the slides. These numbers are maybe a little dated by 6 to 12 months, but you can see the relative number of employees. We have, I think, over 140 employees now with family medicine here on Fifth Avenue in Sequim. We take care of upwards of 18,000 patients and with over 50,000 visits per year. And we'll do a little bit more detail on that. All right, so Jamestown Family Health Clinic, of course, we're comprised of about 20, I think we're up to 21 family medicine physicians, nurse practitioners, and physician's assistants. And of course, we do all things primary care related, from chronic disease management to preventive care to acute care. And like everyone in the healthcare field, we've had to pivot a little bit and fill in some gaps. So some gaps that we filled in, despite excellent services here or beyond, we've brought in a nurse practitioner who exclusively does dermatology. She still is booking out 6 months, no surprise there. We have a physician assistant who helps us with some internal orthopedics before they reach the point of having to get sent off to Dr. Gouge and our colleagues at Olympic Medical Center or beyond. And then we have behavioral health, and specifically on behavioral health, we currently have 5 FTE counselors, licensed clinical social workers or psychologists that do mental health counseling. And they recently moved from our clinic here to the corner of Nickerson, I think it is, over by Dungeness Court. And they have a beautiful little office building over there. In addition to counseling, we also in my 22 years here, we've never had a steady supply of psychiatrists. It's always been a little bit hit or miss. So we are about 5 years into a contract with ClinicWorks, which is a telehealth provider of psychiatric services. So we're able to provide virtual pediatric, well, from about 12 on, adolescent and adult psychiatry. And we can, what's really nice about that, we can expand and contract it as demand requires. So that's worked out really well. And our patients who need psychiatric care, particularly diagnosis, medication management that our family medicine providers aren't able to provide, can do that from their home or wherever they have connectivity. So that is behavioral health. Also, sometimes the question comes up, oh, I hear Jamestown Family Health Clinic has a generous Medicaid encounter rate. Indeed, we do. And what we do with those dollars that we bring in is we're able to staff our clinic. We have 2 clinical pharmacists, and we have a tech, pharmacy tech. And what that allows us to do, we have the pharmacists running our anticoagulation. So those who are familiar with atrial fibrillation and other things that require warfarin, Coumadin, anticoagulation, we have a drive-through anticoagulation shed out back, and our pharmacists are able to staff that and adjust warfarin dosing. They also provide medication review. So we know the demographics here on the North Olympic Peninsula. I'll show you on the next slide some demographics, but we take care of an aging population and people accumulate a lot of meds. And so our pharmacists or their doctorate level pharmacists are able to do reviews and make recommendations. Now, also, when you start looking at chronic disease management, I'll give you an example, osteoporosis in women or men for that matter. But sometimes you have kidney problems, sometimes you have gastrointestinal problems. Some of the traditional medicines we might use for osteoporosis, in addition to vitamin D and calcium, we need a little expertise so our pharmacists can help us out and things like that. In addition to dermatology and ortho, we also have a practitioner devoted to chronic pain management. Now, family medicine providers have to do all these things we're talking about, but sometimes for folks who have been on, particularly needing opioids long-term for the treatment of chronic pain, those appointments can become monopolized by those discussions, and that's fine and appropriate at times. But we want to make sure folks who are being treated for chronic pain are also having their other diseases and preventive care addressed. So we have a provider who can do standalone visits for those type of visits, making sure their family medicine practitioner can make sure they're up to date on colon cancer screening, prostate cancer screening, et cetera, et cetera. And then we have some internal expertise on wound care. Olympic Medical Center has a nurse practitioner devoted to wound care, and I think they also have a physician now, but those things kind of wax and wanes depending on the supply of practitioners. So we have a couple of nurse practitioners who've gotten expertise training, and also our nurses. So all that to say is to look through this list, we do more than diabetes and hypertension. We try to meet the needs of our tribal citizens and the community at large. So just some quick demographics for those interested. I said 18,000 patients earlier, but we have about 16,200 patients. What that means is if you look at Epic, which is electronic health record we're all used to, we are the primary care provider assigned to about 16,200 patients. On a typical day, we're open Monday through Friday. We have Saturday hours for acute care. We see between 240 and 260 patients per day. And that is largely family medicine, but that also would be your behavioral health counseling, your telepsych services, and then I don't separate them out, but folks come in for ortho, derm, and other things. And that adds up to about 50 to 60,000 visits per year. And our demographics here, not surprisingly, is predominantly 65 or older, and then you can 46 on up and see it. So we're the demographics you would expect. And I'm sure that's similar to our colleagues at Olympic Medical Center and North Olympic Healthcare Network. And then in terms of payers, we pretty much take all payers. Medicare is our predominant number. Most patients by patients is Medicare, followed by commercial and or Medicaid. So those are our primary payers. And as you can imagine, there might be questions about this. There are things going on right now that we're wondering and waiting for like everyone else. I'm going to pause here. Any burning questions? Okay.
Anyone have any questions?
All right. Feel free to
Doesn't
jump
sound
in.
like it.
I don't mind being interrupted. Sorry, Colleen, do you have one?
No, doesn't sound like we have any questions.
Okay, I'll blast through. I know I talk fast. I apologize because I want to make sure there are time for questions. So what are the challenges ahead for family medicine? Honestly, if you ask me as chief medical officer, I need more space. I have a great group of providers. I have other folks who want to come work for me. That is a good place to be. And I'm literally out of space. I, without exaggeration, have people working out of broom closets right now. Not the exam rooms. If you come to Jamestown, you get a lovely exam room, but I have practitioners where we co-opted what was a mop bucket and broom closet, and that's their workspace. So I'm literally out of space right now. We have a new physician coming later this year. We just added 2 new providers. And then until someone retires or moves away, we really don't have room for another family medicine practitioner, which is good and bad, depending how you look at it. So space, I would say. Providers and recruitment and support staff. I painted a rosy picture of family medicine providers. Knock on wood, we've been doing well, but also nurses, medical assistants, front desk folks. Those are the heart and soul of what we do here at the clinic. We've been fortunate today, but I know when I talked about bringing on another full-time family medicine practitioner, our medical assistant supervisors looked at me across the room with laser eyes and said, Paul, it's hard to recruit for medical assistants. So we appreciate our colleagues at Peninsula College, Rachel Parrish, who built a great MA program there and is providing MAs. And then, of course, medical assistants. And then there's a lot of on-the-job medical assistant training programs going on you'll see out there. And then lastly, revenue erosion. Our main concern is, like everyone, and including Medicaid. A comment on Medicaid, which is sometimes folks think, well, Medicaid probably doesn't affect me. You know, it's lower income folks and it's this and that. Some of you may know, but if you don't, and it varies from state to state because Medicaid is, of course, a state and federal program. The funding largely comes from the federal, but also the state provides a big chunk of it. And so it varies from state to state, but basically Medicaid is primarily low-income seniors, particularly those in long-term care facilities like nursing homes, and then dual eligible, those that are on Medicare, but their income level is low enough that they also qualify for Medicaid, and then children and pregnant women. And then in the middle is kind of your working age folks. But my biggest concern, beyond what the impact on our OMC, Jamestown, other places, is the impact on seniors. If I didn't say at the beginning, I'm a family doc, but I'm also a geriatric and hospice and palliative care doc. And my passion and love is for taking care of older adults. And I worry about that Medicaid stuff impacting the quality of life, the care of our the seniors in our community. Okay, that's my soapbox for that one. Thanks.
Can you
Dentistry.
share a bit about your payer split, your payer mix?
Yeah, great question, Colleen. So it is, as I put here, Medicare followed by Medicaid and commercial. And I should have tried, I think I tried last night to grab a picture, but I failed. I think because it varies, but Medicare is going to be, let's say 50% loosely, and then Medicaid after that, and then commercial being, you know,
The
employer-based
smallest
insurance and all
amount.
that.
I know that's a huge challenge for OMC, that they talk about, that I think I'm going to be wrong, but I think 13% of their payer mix is commercial, and so they lose money on Medicare and Medicaid, that the reimbursement rates are not don't cover the cost. But as I understand, because you're a tribally owned entity, that you guys get 103% of costs, is that right?
Yeah, so let me respond two ways to that, Colleen. First, I want to echo what you're saying about Olympic Medical Center, because that's first and foremost going on in our community right now. Olympic Medical Center, I think probably all of you know this by now, is it's an untenable payer mix, right? In a perfect world, they used to be able to maintain during the Mike Glenn, Eric Lewis, and now Daryl years, they could maintain a margin 2 to 4%, but they're like 80% Medicare, Medicaid. They lose money on every Medicare, not every, but on a lot of Medicare and Medicaid patients. And so they have to make up with that at commercial. I trained at Swedish in Seattle. Those things are flipped, kind of, sort of. You know, you got 70% commercial, you know, I got Boeing, Microsoft, et cetera, and then 20, 30% Medicare, Medicaid. So the big players in urban areas can more readily, although a lot of them are suffering right now, can more readily make up for those Medicare, Medicaid dollars. But the OMCs of the world, not so much. And then, Colleen, you're talking about, I think you said something about 103%. That's more on the Jefferson Healthcare. And I'm not the expert here, and I want to be careful, but Jefferson, because they are a critical access hospital, at the end of the year, Medicare makes them whole, i.e. they do their accounting, they say, we had $100 million in Medicare, you only paid us 80 million, give us another 20 million. I made those numbers up. Please don't call Mike Glenn and tell him I said that. But that's that. On the tribal side, so all tribes across the nation have a formula and agreements with the federal government in terms of getting enhanced Medicaid rate. And that's a formula that I don't even understand. If Hawk's on the call, he might know more about than I do. But that is that, along with like North Olympic Healthcare Network, which is a federally qualified health center. Whenever you see Jamestown is a tribal FQHC, Federal Qualified Health Center. North Olympic Healthcare is a federally qualified health center, et cetera. So whenever you see those kind of initials in an effort to make sure that Medicaid patients get care in rural areas, in our case, there's agreements to make sure we're not losing money on Medicaid patients. Does that answer your question, Colleen?
Yeah, so it's a plus up for Medicaid, but not for Medicare.
Correct. We do, for those interested in the details, we do work on a Medicare encounter rate also. I wouldn't call it enhanced. Depending on how you look at it, probably it's a wash. If we just did intensity level billing, like level 3, 4, 5 visits for Medicare versus just a flat rate, it'd probably come out about the same, but it's easy for us to do just an encounter rate and call it good.
Mm-hmm.
All right. Dentistry. I said we being Jamestown Family Health Clinic in 2002. Then 2004, Jamestown Dentistry started. And if you don't already know, they're out in Blinn, down by the water side. If you go down, been Red Cedar Hall. Below Red Cedar Hall is their little dental clinic. I'll say a little bit more about that, hoping to expand. But they opened in 2004, primarily adult dentistry. And then Dr. Bree, let me go ahead here. Here we go. Dr. Bree Butler came along, I think about 10 years ago, maybe as far as 14 years ago, and started providing services for pediatric. And the importance of that was before Known and other folks were providing Medicaid dentistry. Jamestown, I think, was the only folks providing dentistry for kiddos on Medicaid. So that's been a really important service. I know for my own daughters, we used to traipse over to Paulsbo, a great pediatric dentist, but for families not to have to leave the peninsula, especially Medicaid patients, Dr. Butler's been a godsend. And then this is our assortment of adult or general practitioners providing adult dentistry. And I won't read these, but they do fairly broad dental care. Now, on the reason that pediatric dentistry has worked out, again, they get a Medicaid encounter rate. So pediatrics, for those who have kids and have seen them go through dental, it's pretty straightforward, right? Kids' teeth fall out. So worst case scenario, they fall out. I don't mean that blithely, but you can do restorative care for kids pretty quick and relatively inexpensive. The problem is for our community and the rest of the country, for that matter, is low-income adults and oral health, because oral health impacts everything from our heart to our lungs to our brain. And that's another concern that we all have around Medicaid, because probably the rumor on the street is that well, I don't want to say anything, but there's a concern that adult Medicaid dental coverage is going to go away. And anyone who's ever had a toothache, et cetera, it's no bueno. You're miserable until you get it fixed. So if you can imagine walking around for weeks, months, or years without dental care, that's pretty horrendous. So Jamestown Dental, and we're out of room there. I said I'm out of room. Well, Dr. Butler and the rest of the gang are out of room. So we're hoping to finance and build a new dental clinic to the south of us, here on 5th Avenue, the field that's to the south of us by the helicopter pad, and we're able to do that, we're going to be able to expand pediatric and adult dentistry. We have another pediatric dentist that wants to work for us full-time. We just don't have enough operatories to do that. Any questions on dental?
No, great. Thank you.
And I think I covered these slides. So I should add that we also have a dentist, Dr. Juarez. She's amazing, and she's at the Healing Clinic. I'll say more about that here in a slide or two. All right, so on to Jamestown Healing Clinic and my colleague, Molly Martin. So unless you were living in a bunker a few years ago, you know that Jamestown actually took the headlines that we're experiencing an opioid crisis, literally. And the tribe elected to pursue opening up an opioid treatment program. And that was one of the things that got lost in that discussion. I'm not going to rehash it. It's open, been going for 2 years, and not surprisingly, meeting a desperate need and doing very well. But what some people back a few years ago failed to recognize is they're like, well, we already have medical assisted treatment for opioid use disorder. And you probably have heard of buprenorphine or Suboxone, those type of things. Yes, indeed, Jamestown, Known, Olympic Medical Center, even some private practitioners out there we're providing Suboxone or buprenorphine for opioid use disorder, opioid addiction. The problem with that is not everyone can achieve recovery and maintain recovery on Suboxone. So then what is your next thing in your tool belt? It's methadone, been around since the 1950s, I think, or 60s, and very successful. The literature actually shows methadone allows folks to achieve and maintain sobriety better or more longer than Suboxone. They're both really good, but you cannot do methadone out of a Jamestown or known or Olympic Medical Center. So it's not like we all could have woken up and say, oh, 20% of our patients are failing Suboxone, let's just start dispensing methadone. It's a whole nother thing. Okay, so that's why we had to open up a standalone clinic that qualified as a, quote, opioid or opiate treatment program. And I won't read through all this. You guys can look through it. But basically, there's a bunch of regulatory agencies, SAMHSA, FDA, DEA, the safe we have it there. If there's a apocalypse, that's the room you want to be in, because it was ridiculous what we had to do to store methadone. But anyway, it jumped through all the regulatory hurdles and has been operating for about 2 years now. And well, July 2022, so over 2 years, right? Yeah. Is my math right? We're going to be 3 years in July. Okay. And 250 to 300 patients. Those are all from Clallam and or Jefferson County. And as probably most of you know, when we opened, it was, I won't say predominantly, but a lot of heroin and other opioids. Now, if you haven't already got the memo, fentanyl is pretty much, I don't want to say 100%, but pretty much close to 100% for those who are dependent upon illicit opioids on a daily basis. And that's changed the face. And I'm not an expert. My colleague Molly Martin and the folks over at the Healing Clinic are, but fentanyl has thrown a wrench into things. We kind of knew what to do with heroin 3 times a day, this amount of grams and all that. Fentanyl is ubiquitous, it's cheap, it stays in your system for a long time. So everyone from the Healing Clinic and across the country has been jockeying to make sure we can help folks who are seeking recovery to achieve recovery and maintain recovery, and it's not easy. Notably for our Healing Clinic, what we also chose to do is address a couple of barriers to care. And whether it's opioid treatment or any others, any healthcare really, what is it? Well, transportation, I can't get there. Childcare, I'm a single parent. I can't leave my kiddo here. So at the Healing Clinic, we have child watch, not child care, it's a whole another thing, but child watch and transportation, where we'll pick folks up and take them back to their home address. And as you can see here, majority of our patients are actually accessing services through our shuttle services. A little demographics, average patient is 40 years old and predominantly women, which is interesting.
Yeah. Hey, question on that, Paul. 90% are from Clallam County, 10% from Jefferson. Clallam's 2.5 times the size of Jefferson by population. Do you think, are there other options that people have in Jefferson County, and it's just the transportation issue that causes that split 90-10, or do we have more of an opioid problem in Clallam County than they have in Jefferson?
Good question. I can maybe answer a couple of them. One, well, first of all, we will provide transportation. So it's not like if you live in downtown Port Townsend, we can't pick you up and take you home. So transportation is not the issue. There is no opioid treatment program in Jefferson County proper. There are folks providing medication-assisted treatment, i.e. buprenorphine, but there are not providers doing methadone. So it's possible either folks are just sticking, with the buprenorphine, they're coming to us, or they might be going across the Hood Canal to Kitsap. There is, I think, 1 or 2 opioid treatment programs over there. Okay. I don't know the statistics, Colleen, on opioid use disorder in Jefferson versus Clallam County. I'd rather not guess on that one.
Okay. So Owen, as far as turnover is concerned, ONC has said they have to deal with about 20% annual employee turnover. What's the metric for Jamestown regarding turnover?
Great question. It's going to vary. Boy, my boss isn't on the line. Brent, if you're on the line, can you chime in? But it's less than 20%. I don't know that number. I'd have to get back to you. We're doing well, but it varies, right? the healthcare profession, people can come and go. Less so if you live in Seattle, you've got a bunch of places. Clown County, you can count on one hand the main employers for healthcare. So a little less movement around, but family medicine, we're generally doing very well. I think Molly over at the Healing Clinic has done very well, but that's a tough job. It's a high stress job, right? Folks in recovery, or trying to get into recovery, in and out of recovery, are proved challenging. So they may have a bigger turnover in nursing, et cetera, compared to us. At the same time, when you sit down in that building and talk to the folks who work there, and they love what they do because they're making, they're seeing the difference they're making. They're helping pregnant women. They're helping new parents, stay together and all that. So while it's a tough job, the rewards are equally impressive. So I think it varies from place to place, but we're less than 20%. I'd have to get back to you on a number.
So when I worked in the HR department, it was 1 to 5% each month.
Oh.
It was very low across the board.
Mitch. I'm sorry, Mitch. I feel
No, you're good. It was surprisingly really good turnover, and just kind of a testament to leadership there.
Yeah.
So are most of your employees coming from OMC, or are you recruiting from out of the area?
Oh, great question. Well, boy, no, it's let me think. As far as my providers, I only have 1, 2, maybe 3 out of 20 that I think originated at OMC. And 1 or 2 from known. So I would say they're de novo to the community, like me, or yeah. So the majority of our providers are from outside the area. New physicians, graduating, et cetera. They're obviously from outside the area. Well, I shouldn't say obviously, because of course, North Olympic Healthcare Network has an awesome family medicine residency right now. And we have one of their graduates, Dr. Kristen Poole. But no, we're not. I don't think any of us are really, quote, pilfering from one another. I think folks find their home and they're happy. I think we're all a great place to work. We all work great together. Myself, Dr. Maxwell, Dr. Weller, and of course the folks at OMC. So I think we're all pretty collegial, and people just. What I see here is there might be someone working, say, at OMC, for example, but they live here, even towards Hood Canal, sorry, east of here, and so they just want to be closer to home, so they might come here for that reason, or they might, we've had people go to Known or OMC again because maybe commute. I mean, I live in Port Angeles, and over the years I've thought about OMC because my commute, I live by the college, my commute would be about 3 minutes versus 27 minutes. But we all make our choices based on personal and professional goals.
Okay.
I'm going to skip, read through there. Just a logistics, and we'll keep going here because I want other questions. I talked about the difference between medical assisted treatment, i.e. buprenorphine, and opioid treatment program, that is the ability to dispense methadone. Well, methadone is given on a daily basis. It comes in a liquid form. If you've ever been to our clinic, there's dispensing rooms. There's a machine, kind of looks like a Slurpee machine, and it's all computerized, and it dispenses the right amount. And a nurse watches you take it, and you dispose of your cup there. Same thing. Some folks are actually getting their dosing of a Suboxone, which is a film. It's like those little breath mint films, if you're familiar with those. And so whatever you're taking, it's observed. And then there's also, of course, random urinalysis, et cetera, et cetera. And then, quote, a take-home dose. Their healing clinic's open Monday through Saturday, so folks get a take-home dose. So they come in Saturday, and they get it. They have a lockbox, and they can take a dose home for Sunday. Now that has to be earned, and it's highly regulated. And a few examples: you cannot, you can't be using other substances, right? So your urinalysis has to show that you are indeed sober, and I think even like alcohol, you can't be using alcohol, or even cannabis, of course, which is ubiquitous. And again, I'm not an expert on this, but there's some specific rules by either SAMHSA or other regulatory agencies that dictates who can and cannot have take-home doses. I also want to mention it's not only Sunday. Some folks who have been stable on their dose for months to years actually can get many days of take home. So it really varies.
Right.
Then people ask, what about other drugs and alcohol? Sorry, ETOH is alcohol. A significant number of patients who have opioid use disorder also are using other medications, i.e. polypharmacy, whether it's methamphetamine, cocaine, other things. And in fact, something that's been observed in the last couple of years is folks became opioid dependent without even intending to, because fentanyl is in so many things these days. So they thought they were just doing methamphetamine. In fact, they were also using fentanyl unbeknownst to themselves. So they became dependent on opioids. So it's a weird mix out there. But what I want to say about that is, while we have very successful evidence-based piles of literature for treating opioid use disorder, not so much for stimulant use. And of course, alcohol, actually, there is some better treatments now beyond sobriety and 12-step programs. But so to the extent that there are treatments available for those, the Healing Clinic will provide those. But unfortunately, for things like methamphetamine, not great options. There are some things out there you may hear about, like gabapentin and other things, but not nearly as successful as methadone and or buprenorphine.
So a couple questions, Paul. First of all, what does SUD stand for? Most JHC patients have multiple SUDs.
Oh, sorry, substance use disorders.
Okay, got it. And
Yeah,
let's see, Mark Fisher had a question, but his virtual hand isn't working. Mark?
Hey, good morning, folks, and thanks a million, Paul. Good to see you. Here's a a crazy premise. Some would think that the fentanyl epidemic will diminish, and there's a lot of activity, of course, nationally to reach that goal. Your business model for this beautiful facility is dependent on the fentanyl epidemic continuing. And I wonder if in your folks' thinking, at a time we would wishful thinking that there'd be less of this addiction problem, what your view is on that. If you look at some of the statistics, there's maybe already been some traction in that area. And as a crazy thought, it might free up some room space for you.
Yeah. Hi. Hey, Dr. Fisher, thanks for joining. Great question. I love your optimistic outlook. And I think if any of us had a magic wand, we would wave it, and tomorrow there'd be no opioid use disorder. And if you look at this picture right now, that's a lobby. And if you go through this door, there's a bunch of behavioral health counseling rooms. If you go through that door, there's dental. Go through this other door, there's primary care. I would love nothing more than to wake up tomorrow and Chairman Allen says, Paul, you can have this, and hire 8 more family medicine docs and 8 more, behavioral health specialists. So to answer your question, if we get to a point where we do not have a bunch of folks dependent upon opioids and or different models for treating them, that they don't have to come in every day or nearly every day for methadone, we would gladly use that space for something else. But I haven't seen promising statistics to say that we're on the verge of solving this problem, unfortunately.
So another question is from Rebecca, is recovery and therapy for fentanyl the same as other opioids?
Great question. So of course, if I didn't make it clear, fentanyl is an opioid similar to heroin, oxycodone, morphine, et cetera, et cetera. And the treatment is the same. I alluded to the fact that I'm not an addiction medicine specialist nor a methadone dosing specialist, but fentanyl, the pharmacology, how often you need to use it, how long it stays in your body, how soon you start to go through withdrawal treatments is different than, say, heroin, so the models for treatment are the same. That is methadone in opioid treatment program, but the dosing, where my colleagues over there have been challenged, is having to develop new dosing regimens, because again, highly regulated environment where the regulatory agencies will say you can only start here and only go so fast on that. And fentanyl has kind of thrown a hand grenade into the old models of how you dose methadone. But otherwise, same thing. And I glossed over it. Let's see. Oh, yeah, let me jump to this slide. So in addition to providing methadone and taking away some of the barriers, transportation, childcare, et cetera, what we're trying to do is provide a place where folks can not only get into recovery and maintain recovery, but get well. And that includes, so right here, we also have chemical dependency counselors. We have behavioral health counselors. The one slide said many of the patients have at least one mental health diagnosis, depression, anxiety, post-traumatic stress, et cetera, et cetera. So we're able to get them into both chemical dependency counseling and behavioral health counseling. We have primary care there to deal with both their acute issues and chronic issues, not the least of which we're able to treat hepatitis C infection on the spot there. And then if you go through this door here, you'll, I don't want to lie. Yeah, if you go through that door there, eventually you'll get to the dental clinic. So we also have 3 or 4 dental operatories. So if you can imagine, some of these folks maybe came to their original use of opioids in a medical setting. They were having oral health, couldn't access dental care. And next thing you know, they've been taking oxycodone and hydrocodone for months to years on end. And then that prescription gets cut off. They go to illicit street drugs and that kind of thing. So being able to treat people's oral health is really key. So whether it's fentanyl, heroin, or other opioids, what we're trying to do is, number one, take away that craving. If you ever talk to anyone who is addicted to an opioid, they long ago gave up the idea that they're going to have a pleasant buzz, right? I mean, that is a long time ago. They're now trying not to be sick. They're trying not to wake up and be sick and get on with their life. So the first thing you need to do is stabilize them from that opioid withdrawal. And then from once you get there, then you can start chipping away at what are the issues that led to that substance use disorder. I hope that answers the question. And then this alludes to some of those things. I'm glad I put a lot of slides on here because I figured you folks would be particularly interested in this part of it. And this, of course, is the child care watch. So imagine some people need to get to work. So they roll in at 6 a.m. We start dosing at 6 a.m. And so some people are rolling in 6 a.m. and on that particular day, they just get their dose and then they're off to their job, school, or whatever they're doing. Other people are coming in and they're going to have a dental appointment. They're going to have a medical appointment. They might be meeting with their chemical dependency professional, et cetera, et cetera. So they might be there from 1 to 3 hours. And if they have a little one, they can be here while their mother or father is off getting the care they need. Okay, I won't read through all this, but for those, and to the person with the fentanyl question, there's a lot of ways to address addiction or substance use disorders. And there's one-on-one counseling, there's group counseling, and then if you look at this list, just connecting with other community resources for support and so forth and so on. I'll let you read through those. So it really, they tried to tailor the management plan and the recovery plan to the individual. I think we hit on some of this. These are some noted trends, not just at our clinic, but beyond. A lot of overlap between opioid use disorder and other disorders. And unfortunately, fentanyl has contaminated the whole drug supply chain out there. I mean, if you're like me, I have a 21-year-old and 22-year-old daughter. Every time I see my daughter, she lives in Bellevue, I'm like, do not take anything that's white. I don't care what form it is, who you think it came from, because you just don't know. Those of us who grew up in the 70s and 80s, you know, whatever, we're not going to go through what we did back then, but things were a little simpler, a little safer. Our youth and anyone playing around with street drugs right now is kind of really at danger for inadvertent overdose. And then we haven't even talked about some of these things that are out there like Trank and xylazine. And when you start injecting these things and the infections and so forth and so on. So when you're talking about treating folks with opioid use disorder and hopefully ultimately wrap your arms around them and help them with other substance use disorders, you're not only treating them for that addiction and hopefully getting them back on the path to recovery and a life, but you're also reducing risk of infectious disease, hepatitis, HIV, skin infections, all those type of things. So there's a lot going on there. And these are some of the trends. I think that's it on this slide. And I just have a few more slides, but any other questions on the Healing Clinic?
No, but we have one from Mike, who says, you mentioned dental could be cut in Medicaid funding. Similarly, insurance companies generally provide substandard coverage of mental health and dental claims. Do you believe the healthcare industry will change in the future to give parity to mental health and dental coverage? And he says your presentation is very helpful. Thank you.
Yeah, Mike, thanks for the question. Outstanding question. I would love for that to happen. And let's give credit where credit is due. In Washington State, in the last 10 years, there's been more than just giving words to this. You know, the state of Washington has really tried to up the ante with covering mental health, behavioral health, also with dental. So I think at least in Washington State, there's been some good stuff going on. As far as coverage with Medicaid, for those who have Medicaid, there is coverage for mental health. The challenge, whether it's Medicaid, Medicare, or even commercial insurance, is access to mental health professionals, right? So I can tell you that our counselors are booking out a couple months, usually a couple months, and then our telepsych is a little easier to get into because we can flex it as needed. But if you just look across the board, whether it's Clown County or beyond, there are lines to get into mental health counseling. I think dental especially. Excuse me, when it comes to Medicaid, you know, a lot of private dentists, I think they try to do their part, but it's like Olympic Medical Center. One of the reasons Olympic Medical Center is in the pickle they are is because they, for better or for worse, cannot pick and choose. They are a public hospital entity. They accept Medicare dollars, so they have to take all comers. They cannot turn people away. And so they're in a predicament. If you're in private practice, whether it's medical or dental, you can pick and choose your payer mix to maintain, you know, a sustainable practice. No one wants a private dental clinic down the street to be, you know, to go out of business because, you know, 50% of their clients are Medicaid and they're paying less than the cost, and or that cost goes away. But Mike, we are all worried about the impact of Medicaid and whether it has to do, I think dental for sure. I don't think mental health reimbursement for Medicaid is going to go away so much as just the ripple effect, right? I got on my soapbox earlier and said, whoa, if you don't think Medicaid is going to affect you because you're not an elderly and low income or a little kid in low income. But just think about Olympic Medical Center, what's going on right now. Think about the challenges they've had with their emergency room. By the way, I've had outstanding care OMC emergency room, so it hurts my heart when I go online and see these things. You know, ERs are tough. Olympic Medical Center has one of the highest per capita volumes through their ER. You know, a little plug to my colleagues OMC. I think they're just doing a fabulous job with what they were given. But back to Medicaid, if you start taking, the first thing that's going to go away probably is expanded Medicaid. And for those who are like, what the heck is that, Paul? You got Medicaid, which is like 100, don't quote me on this, but 140% of the poverty line, which is whatever, someone out there can throw these numbers around, say it's $35,000. Another 40% you qualify for Medicaid. Then expanded Medicaid came along in part with the Affordable Care Act, went that up to like 200%. Again, don't quote me on those, but the idea is we have more people qualify for Medicaid. That means across the country, I think somewhere like 20 to 30 million people who were uninsured now have insurance. If the federal government starts cutting Medicaid and states are put backed into a corner, what are they going to do? They're going to start chipping away at that expanded Medicaid. So both in Washington State and across the country, we're going to see less people qualifying for Medicaid. And, you know, again, a little bit of a soapbox. We all know people who are working. We know people are working full-time plus, and sometimes they don't have medical insurance. They're dependent upon Medicaid. So yeah, the Medicaid thing should have all of us worried. It has me worried for sure. And how it's going to all play out, we don't know. Okay, so I see we're running low on time. I would say the healing clinics continue to try and grow and meet capacity. The big thing with the healing clinic over a year ago, started a mobile medical unit. We bought an RV, had it converted, and they've been driving out to Clown Bay. Kudos to the fire chief out there who allows us to park there. And not surprisingly, the west end of Clown County, they're already at capacity, something like 30 patients plus a day when we're out there. And because we're limited by RV size and all that, I think we're bumping up against capacity issues. There is discussion of the regulatory agencies loosening things up, and perhaps at some point we or someone else can do a brick and mortars building out on the west end. But I know there's other entities, some other tribes and stuff, and that may be working on those things. Okay, that's Healing Clinic. If you've never driven by there, please feel free. It's lovely. Take a look, especially in the twilight or early morning hours. And then I'm going to kind of skip through this other than to say Jamestown Wellness Program. This is related to tribal citizens and all that. And I skip it just for this group, not to discount, because first and foremost, Jamestown Family Health Clinic and our other healthcare entities are here to serve tribal citizens, their descendants, and the community at large. As you can tell, family medicine, 16 to 18,000 patients. The tribe is less than 500 citizens. The tribe believes greatly in providing care to the local community because they believe we're all part of the same community. But we are here first and foremost to meet their needs, and there's some other things we provide for citizens and beyond. And I would say, I think this is my last slide, second to last slide. What's going on? This is a timeline, 2025. I'll finish with a slide coming up. We have broke ground for, let me go ahead. We have broken ground for a 16-bed psychiatric evaluation and treatment facility. If you know where the Healing Clinic is behind Costco, between the Healing Clinic and Highway 101, the westbound lanes, is right now going up this building you see before you. The foundation is poured, and I'm told by this summer, there will be a roof on. So with an opening as early, I think spring of next year. Let's say spring of next year. Now, a lot has to happen between now and then, and not the least of which is ensuring that we can get a daily rate that makes it sustainable, because the state, all of us taxpayers are building this particular building, but the ability to actually staff it and take care up to 16 patients a day depends upon the daily rate. So that's still in the works. But I will say here then, this is under construction. The tribe is moving forward with a new dental clinic to be to the south of us here by the helicopter pad. I don't know much about this, but I know Molly and her team at the Healing Clinic have been working with sheriffs. What's Brian's last name? Smith?
King? Brian King?
Oh, sorry, Sheriff King, and try and bring some services to the jail that might not currently exist, specifically daily dosing. And then 2026, we're anticipating our psychiatric hospital opening. I could take some questions on that. Dental clinic beginning, and perhaps in 2027, dental clinic opening. And then I won't go in detail here, but then of course there's some flux and some leadership here at the tribe, but we don't need to go into that here. That concludes my remarks. Thanks for your attention. I know I went long, but I'm happy to take a few minutes questions if that's what you guys want to do.
Well, thanks. Stephen had his hand up. Stephen?
Sorry. Thanks, Paul. This is great. Look, I'm a financial analyst. I love digging into the Port Angeles and colonial economies. You mentioned that Jamestown Family Medicine headcount was 140 today. I'm seeing Platypus up, Westport down, McKinley obviously down. What was your headcount pre-COVID?
Yeah, so great question, Steve. So we see between 240 and 260 patients a day, Monday through Friday. Before COVID, we were probably around 200. With occasionally bumping into the 210, 220. So we've grown, and we've 5 years ago, for example, Steve, if someone came around and said, hey, I just want to work a little bit, I'm retiring here, but I'm not ready to retire. Can I work a few days a month here? I'd be like, yeah, come on in. Now things are so tight, I can't do that. So We're wedging people in. You know, I'm watching housing go up, you know, that senior park to the east of me. I walk there out the back, and I'm watching stuff going up on River Road, et cetera, et cetera. And I don't know what's going on with the John Wayne Marina and all that. So yeah, we're if anyone sees Chairman Allen or anyone else on the council, please say Paul needs a bigger building. But they you know, look, the tribe has been amazing. Just in the time I've been here, this building I'm in is essentially new still. You know, the healing clinic, the psych hospital is coming, a new dental clinic, including services for low income and Medicaid. I think it's hard to ask for more from the tribe. So between us, Olympic Medical Center, that's why I'm deeply hopeful that Mr. Wolf and his team at OMC will be able to come up with a solution. We need Olympic Medical Center to be strong and great. We need those specialty services. My colleague Mark Fisher can say plenty about that, but all the specialists in this town are basically OMC. And then, you know, for anyone who has to drive off the peninsula for care, you know, we can all drive to the ferry, go up to First Hill, UW, wherever, and, you know, navigate it. But if you can, sorry, make sure my computer doesn't turn off. For others, just to get to First Hill, Pill Hill, and all that, little kids, even getting a kids app is hard. So I'm really hopeful OMC and others, you know, we have a great, Steve, we've had, you know, I've been fortunate. I came out here after graduation. I never left really because it's always just been such a collaborative community. And, you know, we saw that during the pandemic. You know, the tribe was fortunate. We got vaccines before some others, but we came together with the emergency response group in SQUIM. We came together, the Olympic Medical Center, Dr. Berry, the public health. And like this community knows how to rally. So I'm very hopeful for healthcare in the future. But yeah, for those who are looking for the Olympic Peninsula to grow and by another, I don't know, 10,000 people in the next 20 years, something's going to have to give. But I definitely need a bigger building if we're going to grow.
Thanks, Paul. If I could just do a quick follow-up to that. I mean, OMC's now lost money for a few years. It seems like their 2 to 4% net margin model is impossible to get back to. You know, what's the comparable for Jamestown? Do you guys run at a 2 to 4% net margin there as well?
Great question. I don't know. I honestly don't know our margin, Steve. I will say this. When I interviewed for my job 22 and a half years ago with Cindy Lowe, I remember one thing she said to me. She said, you know, the tribe's not going to operate a business if they cannot maintain profitability, right? Because without a margin, you have no mission, right? And so we've always been profitable, and and we're fortunate in that regard, and we can turn that profit over into if you were here at the beginning of the talk, Steve, you know, having things like clinical pharmacists, I left out a bunch of people, dietitians, diabetic educators, and we're really fortunate to be able to have that right here, and that comes from those dollars, right? So, and those dollars, sometimes people talk about our Medicaid reimbursement rate. Those are federal dollars coming into the community that would not otherwise come in, because the state of Washington is still going to pay whatever they're going to pay. So that difference is made up by the federal government. So, yeah, I think the tribe has done an outstanding job in my 22 years here of stepping up, opening Jamestown, dental, pediatric dentistry when it wasn't available, particularly for low-income kids. And I'm confident we'll continue to step up. But with current construction items going on, I think primary care is on pause for the near term. I did try to whisper in Chairman Allen's ear about that JCPenney building. I was salivating over that, Steve. If you gave me that square footage and whatever, put a couple $1 million in, I just need a bunch of exam rooms, right? And but lo and behold, we didn't have that. So between us, Olympic Medical Center, and Known, I think we're going to have to figure it out, unless we'll see what happens to OMC. If a big player comes in the community, next thing you know, they could put up a big primary care clinic somewhere, and that might be the solution. I used to feel a little more protectionist, Steve, and now I'm like, you know, the world is changing, evolve or die, right? And I think Jamestown, I know Jamestown's going to be a part of the equation for the next 20 years. But whatever other players come in, we're ready to play ball with them and do our part.
No, thanks, Paul. Really appreciate it. It seems like, you know, 1,000 people are migrating to Clallam County, and we've got 900 parcels that are being built around SQUIM. It seems like you guys have a strong need over the next 10 years or so. So I really appreciate your efforts.
Agreed. Thanks for the question, Steve.
Yep.
All right, thanks, Steve. So we are at 9:01, and Dr. Cunningham, really appreciate your time and your presentation. And I see, we'll go ahead and close this out. I see, Marcia, you have your hand raised, and we'll ask that question after we close it out. But
And
thanks
Colleen,
again,
can I just
everyone.
say
Yes,
something?
Paul,
Sorry
go
to
ahead.
speak over you. I did leave my email on there. If there's burning questions, my email is pcunningham@jamestownhealth.org. P Cunningham, like Richie Cunningham, Happy Days, @jamestownhealth.org. And
Great.
feel free to send me a message. Just be kind, and I'll happy to get back to you.
Great. Thank you so much, and enjoy your day, everyone.